Last night I had a debate with another leftist about the usefulness of wearing a mask to fight COVID. I posted my video with science and facts presented by doctors. They don't work, but this respiratory therapist came back with, well then, have your doctor do surgery without a mask. Well, here you go dummies. A long and boring one, but it still says you're an idiot. An article by the Journal of the Royal Society of Medicine. Unmasking the surgeons, the evidence base behind the use of face masks in surgery. The use of surgical face masks is ubiquitous in surgical practice. Face masks have long been thought to confer protection to the patient from wound infection and contamination from the operating surgeon and other members of the surgical staff. More recently, protection of the theater staff from patient-derived blood/bodily fluid splashes has also been offered as a reason for their continued use. In light of current NHS budget constraints and cost-cutting strategies, we examined the evidence base behind the use of surgical face masks. Examination of the literature revealed much of the published work on the matter to be quite dated, and often studies had poorly elucidated methodologies. As a result, we recommend caution in extrapolating their findings to contemporary surgical practice. However, overall there is a lack of substantial evidence to support claims that face masks protect either patient or surgeon from infectious contamination. More rigorous contemporary research is needed to make a definitive comment on the effectiveness of surgical face masks. Picture a surgeon operating in a theater, and chances are that you will imagine them wearing a surgical face mask. Masks are a quintessential part of the surgical attire that has become so deeply ingrained in the public perception of the profession. However, even today, it remains unclear as to whether they confer any tangible benefits to surgical outcomes. As efficiency and cost-cutting have increasingly become the topics du jour in the National Health Service, it seems reasonable to assess the efficacy, effectiveness, and cost-to-benefit ratio for this particular component of the surgical uniform. Methodology: we searched the PubMed Journal database and Google Scholar with the search terms surgical face mask/mask, splash, contamination, infection, and outcomes in order to identify salient publications. We also searched the guidance on surgical site infection from the National Institute for Health and Care Excellence. Furthermore, a manual search of reference lists from relevant papers was performed. Contemporary Attitudes to the Surgical Mask: a contemporary questionnaire-based study, which attempted to assess the attitudes of surgeons, revealed that 96% of responders wore face masks. 1 About equal numbers did so with the primary aim of protecting the patients compared to protecting themselves. However, it was also found that 20% of responding surgeons wore the mask for the sole purpose of respecting tradition. Furthermore, 30% of responding surgeons felt that masks could make surgery more difficult by increasing breath condensation on spectacles, endoscopes, and microscopes, and thereby obscuring vision. In May 2014, the first installation of the Glass Surgery Project was broadcast to viewers around the world. This project, based at the Barts and the London School of Medicine and Dentistry, was the first of its kind to live stream a surgical procedure, using new Google Glass technology, to any medical student or trainee with an internet connection. Mr. Ahmed, the lead colorectal surgeon, elected not to wear a mask while performing the open right hemicolectomy and partial liver resection in question. In the immediate aftermath of the broadcast, Mr. Ahmed came under scrutiny from various medical comment threads, blogs and chat rooms on the internet, questioning his decision to omit the face mask and whether this might have compromised patient safety. Protection of the patient: the face mask has been used in surgical settings for over 100 years, first described in 1897. At its inception, it consisted merely of a single layer of gauze to cover the mouth, and its primary function was to protect the patient from contamination and surgical site infection. This practice was substantiated, at the time, by a recent discovery which demonstrated that bacteria could be disseminated from the nose and mouth during normal conversation, as observed by bacterial colony growth on strategically placed agar plates in theaters. In the 1940s and 1950s, antibiotics and aseptic technique came to the forefront of infection control strategies within the surgical setting. Until recently, it has remained unclear as to whether bacterial colony growth on an agar plate was a direct correlate of surgical site infections, and also whether the purpose of the surgical mask has been superseded by more modern strategies of infection control. In order to advocate the validity of an intervention in medicine, it must satisfy 3 levels of evidence: efficacy, effectiveness, and cost-effectiveness. 4 In the context of face mask, efficacy is whether masks prevent the propagation of droplets derived from the mouth and nose of the operating staff. Effectiveness is whether efficacy translates into a significant reduction in surgical site infection morbidity and mortality. And finally, Cost effectiveness determines whether the cost-to-benefit ratio of this effect would be desirable compared to an alternative course of action. Intuition would suggest that face masks offer a physical barrier preventing the emanation of droplets from the oral or nasal passages and therefore satisfy the efficacy requirement of the evidence ladder. However, there are a number of different hypotheses as to why this may not be the case. Venting is a phenomenon whereby air leaks at the interface between mask and face which can act to disperse potential contaminants originating from the pharynx. 5. The accumulation of moisture, during prolonged usage, may exacerbate this problem by increasing resistance to airflow through the filter itself. Moisture accumulation is also thought to facilitate the movement of contaminants through the material of the mask itself by capillary action. These bacteria can subsequently be dislodged by movement. Friction at the face/mask interface has also been demonstrated to disperse skin scales which can further contribute towards wound contamination. 6. In the modern era, there has also been a scarcity of experimental evidence to support the effectiveness of face masks in the prevention of surgical site infections. The earliest retrospective studies 7 failed to demonstrate any statistically significant improvement in surgical site infection rates following the use of masks. Indeed, the latest National Institute for Health and Care Excellence guidelines on the matter do not require operating staff to wear a mask in theater. 8. This decision was based primarily upon the findings of a Cochrane systematic review. 9. This review was guided by the findings of two particular randomized/quasi-randomized control trials. 10,11 The latest update of this review 12, which was amended after the publication of current National Institute for Health and Care Excellence guidelines, included one further study. 13 The Cochrane Review 12 searched through 6 established databases, Appendix 1, looking for randomized control trials and quasi-randomized control trials investigating surgical outcomes comparing the use of disposable surgical masks with the use of no masks. The authors limited the scope of their analysis only to patients undergoing clean procedures, whereby the operating procedure does not enter a body cavity or viscous normally colonized by bacteria. The review chose not to investigate the role of mask in clean contaminated or dirty wounds, as one would expect that masks would contribute less towards the prevention of surgical site infections under such circumstances. Primary outcomes of postoperative surgical wound infection and secondary outcomes of costs, length of hospital stay and mortality rates were ascertained. Insert Table 1. 3 studies were identified as fulfilling all the selection criteria of the review. 10,11,13 A total of 2,106 participants were identified across the 3 studies, Table 1. All the studies reported on the primary outcome of postoperative surgical wound infection, none of the studies reported on any of the secondary outcomes. Furthermore, identified studies were assessed for risk of bias based on 8 specific criteria. Insert Table 2. Statistical analysis of the extracted data revealed no statistically significant association between mask usage and the incidence of surgical site infection. The study concluded that it is unclear whether the wearing of surgical face masks by members of the surgical team has any impact on surgical wound infection rates for patients undergoing clean surgery. However, each of the studies included could be criticized for risk of bias,